long day, too much work we need to do today, and we start our workshops. It will be today in program. If you have a program, we have 5 workshops on the sawbone, and the first workshop will be dedicated to the transverse fracture of the tibia, this clinical case like you see here. Now it is attached with the plate, but we disconnect it later when we put the first rings, and after that I show you how we may manipulate the fragments to reduce this fracture, to adjust the fragments of the bone, and to stabilize this fracture of the tibia. Okay. Now we start with this workshop. For workshop, we prepare 4 rings. This is full, maybe you see it like this, but later I show. This is 2/2 ring, like 2/2 ring connected with a bolt, like you see here. This one bolt here. And now we connect it, we put another bolt. And for the fracture of the tibia, we usually use 4 rings. We need 4 rings because it will be stabilized. We need 2 rings on the proximal part and 2 rings on the distal part. We prepare this system, and 1 ring, I do like this. After that, we prepare another one, another ring. It is connected with a bolt, like you see here. Okay. We put another one. It should be tightened with the 2 wrenches, like this. Okay. Tighten the bolt. Okay, the same we do with the first one. Okay. After that, what we do, we choose the length of we need to see how it is along the fragments. In this case, this is the proximal part of the tibia. It is exactly in the half, and I should choose the rods to connect this. I look at for this. It will be plus minus this rod, like you see. This rod 120 millimeters. If your distance is more or the fragments is shorter, we choose another rod because there is different size. This is 100, 120, 150 millimeters. What we do now, we connect them, these 2 rings, with the rods. Okay, like this. Usually we choose maybe 4th or 5th hole of the ring, because this connected bolt, we position it exactly anteriorly. And after that, we put this rod on the 4th hole, on this distance it for this center bolt. We put 2 nuts here. 1. And we call it tamburo in Italian. It's like a 2. Okay, the same we do it in the 4th hole. And this way, these rods don't influence it of doing X-ray or fluoroscopic control during surgery. And you see, radiologically, you see really good the bone that will be reduced. Okay, we put 2. tighten usually with two, always use 2 wrenches, like this, Okay, rotate now. We prepare another 2 rods, the same position as the 4th hole. Okay, the last one, 4th row, 4th hole, we connect them. Okay, let's see. This is the system for the proximal part, and the same we prepare just in the beginning for the distal part. And put here. If during demonstration you want to give me any question, better you do it immediately or later, how you want. In any case, I'm ready to answer. Okay, this is another one. Tight them. Yes, usually it should be done with assistant. Assistant stay in front of me, but today for demonstration we stay near of each other. But normally the patient stay here and the assistant from another side. We do the same job to connect these two rings. I use again the same length of the rods because, like you see, this permits me to distribute all the rings on the length of the leg. I use the same hole, 4th hole. And this way they don't overlap with each other. One. The patient, after that I show you, the patient for the treatment of the fracture should be positioned on the table, normal table, operation table, but it should be done skeletal traction because the patient been right in an emergency room. Usually it will be done or external fixator. It's like a monolateral. It's for the temporary fixation, or usually it is skeletal traction on the calcaneus bone. And when the patient in the operation room, or just we have it skeletal traction, or it should be done. It means you need to touch the foot, skeletal traction of the Kirchner wire, and the traction in the way that fracture remain just a little bit realigned. In this situation, we can do this, but I think you are orthopedics, you imagine how it will be done for the treatment. Connect them. All this ring is parallel, like you see, because if you use the same length of the rods, the rings became parallel automatically. Okay, we'll leave it like this. Okay. The same position, fourth hole. 1, 2, 3, 4. Okay, now you see the system is ready for reduction. What we do usually, we start the surgery from the proximal part. We prepare the wire. The first wire I want to put, it will be normal Kirchner wire, no olive wire, because olive wire we will use for reduction of the fraction. But now I show you this is classical Kirchner wire or wire with the tip, particular tip. This is the first wire. We may do it, it is better to do it on the fluoroscopic control. In this way, we see the line of the knee joint. We see the proximal part of the tibia, because you know the tibia, it is like an anatomical axis in the mechanical axis are overlapping. It is exactly perpendicular. It may be only 3 degrees of inclination in varus, but no, we do it exactly parallel to the joint line. It is easy to manipulate. Okay, I use here this guards, which is a paper, but usually in operation room we use wet guards with alcohol, L-chlorhexidine. I put this wire okay, like you see, parallel to the joint. Okay, and now what we do, we start building our system. The first things that I said before, this bolt, connected bolt, should be exactly anteriorly. Usually we designed the patella in the way you see patella exactly in anterior-posterior view. We realign the patient with patella exactly in vertical. In our bolt, it will be the same position like a patella. In this way, you have a good orientation, because now you see the bone it looks straight and nice. But if there is a fracture, everything is displaced, you don't see so good the bone inside of the soft tissue. Okay, this is a good position now for orientation, and we put the slotted bolt to fix this wire. This wire, we do like this. Okay. 1 second. No, maybe not. Okay, keep this, please. Yeah. Yeah, the ring, it will be just a little bit more posterior because you imagine the soft tissue, the muscles, volume, it's much more bigger posterior. It's just a little bit up. No, like this. Okay. Yes, assistant usually keeps the ring, and I do it. Manipulate. Okay. Like this. You oriented this. Okay. Another one. Okay, what I do, I tight on one side. And here I should do the tension. Oh, yeah, this wire permits me shifting inside of the bone, like it's possible to do inside of the bone, or shifting on the bolt. Now I tighten it better again because I centered my ring on the tibia, on the proximal shaft, and I use the tensioner for doing good tension of this wire because it's a really important thing. We do it at quite maximum, like 130 degrees here on this tensioner. With this wire, like you see before, it's quite in the horizontal plane. We keep it a little bit like this. We need to use another one, another wrench if you want to keep it better to use 2 wrenches. Okay, did it. Perfect. Now after that what we do, now we have just a little bit of fixation. The second step what we will do, it's not so comfortable. Because our system is here, it's not so comfortable. Okay, because we have this instrument, it disturbed me to mounting the frame. I remove one rod and I'll change position of this rod later. Okay. So now you see here we may orient the distal ring, and it will be done the same precision. But I think for simplify our job, we connect them directly now, because this 2 system, 2 tamburos, should be connected with the rods. What we do, like you see here, I should choose the length of the rod enough to connect the rings here like this, but I need to remember that maybe during reduction procedure I should do again the traction, because frequently the bone is overlapping and there is not enough skeletal traction. For this reason I need to change it. Better don't use this short one, but we will use again a little bit longer, 120 again. Practically we use all of them the same length. Okay, we put the nuts. I don't use a long rod in this situation, because like you understand, if we may use the long rod to connect all of this ring, but these rods will be not functional because it will be not possible to manipulate the system, and you can do really comfortable skeletal traction. But in this way, when I put separated rod, it is easy to adjust the system separately. Okay, we put this in a different holes. Like you see, the fourth hole is occupied now here, and we shifting maybe 2 holes below, for example, or 6th hole. Okay, we do it parallel, one of other, adjust it, and we leave one part of the rod a little bit longer, like you see here. I leave 1.5 centimeters plus minus. In this way I may do distraction for the reduction of the fracture. I'll put it here. Another one. Okay. They should be the same length. You may measure it, or if you want to be sure. This way, all our system became realigned. We put another 2 rods, posterior, and the same hole, 6, 3, 4, 5, 6. Okay. This is our system. I put again a 6th hole. I leave it a little bit longer from one part. I hope you see it. Okay. I tied one part better. This is short part I tied it with the wrenches. This. A long part I don't tie too much because I need, like I said, we need to do distraction here. Traction, and I don't tie it. Okay. Obviously now this system is not stable. We should orient the proximal part parallel to the bone in 2 planes, and the distal part parallel to the distal part of the tibia. What we do now, the second step, we put the wire on the distal tibia. Okay, we use the same smooth wire, not olive wire, because it's easy to shift in the inside of the bone. And we may use fluoroscopy again for doing this procedure. We see it. We don't have here the fibula, and but we have a pieces, and usually the first wire we don't put on the fibula in tibia. The fibula we fix it later, because if there is a fracture of the fibula, it should be fixed, but more important to reduce the tibia, and the fibula may be a little bit displaced. It's not so important for us. But in any case, I want to show you here that the first wire that we put, it is not on the fibula just a little bit posterior. We put like this. Okay, I prefer to put it exactly on the level of the ring. We should look it for this. Put the wire. parallel to the ring, and yes, you should see the height of the ring. That should be the same proximal part and the distal. You may measure it a little bit by hand like this. See what is the distance. Proximal part is bigger. It means that this distance from proximal to distal, it will be different. Distal it should be a little bit more higher. Okay, now we attach it with the bolt. I ask assistant keep it like this. Okay, like this. Another bolt here. Yes, this double line of the holes isn't comfortable because we may choose different holes, and it's much more comfortable to do attachment of the wire on the rods. Okay, and I'll tight one part like this. What we do with this part, if there is a tip should be careful. Usually I cut it from one part here, and we bend it. Somebody wants to broken, we'll see, but for now we do the classical way. We bend it this way. 3 steps, which I use one time you do it 70 degrees, second 100 degrees, a third you go inside. It will be positioned on the bolt in the way that this wire don't disturb other holes of the. Okay, we should tension this wire really good. Tight it. And now our frame is just a little bit realigned. You see the distal corresponding or the distal fragment proximal to the proximal fragment, and theoretically you just adjusted a little bit of the fracture. But now it's not so stable frame, obviously, and what we do, we adjust a little bit this position. Again, we may shift in, we may look in better for position of the frame, and only after that we put another wire, proximal and distal wire, again. Because in this situation the frame and adjustable, we don't need to do it immediately so stable. For us important to do the skeletal traction. Now we do this wire maybe put in from this side, from the medial by assistant, or I do it again from the lateral, and the way you see it better. Okay? Usually I do it again below the ring. The first wire I put above the ring, and the second I do below the ring, in the way it will be good tension, and they will be crossing. We don't need too much crossing here. I close one eye and I look into the ring, into the wire, in the way I may stay exactly parallel to the ring. And I put my wire that touched the ring in this way. Okay. I use bolt, slotted bolt. Like this. Okay. I tighten it again, good. Another bolt from on this side. And now I tension it. This way the two wires, there are not so big angle between them, but they not guaranteed translation, but in any case this crossing position permits us to stabilize much better the proximal part of the tibia. I tension it again. Classic. Okay, fix it, release good, perfect. Okay, we cut this tip, okay, and we put another wire, distal part, again. I remove watches, and this way I see my time. Okay, we have time. Okay, the second wire always in the distal ring. Like you see, you understand me, these two rings in the middle, in the beginning they're empty. There is no wire and there is no any fixation in the middle. We do only proximal and distal part of the tibia. Like this. I hope you see it. Okay. We put the bolt. And I tie this wire. Yes, if you don't want to cut it and do in this procedure, you may block it. If you prefer it, it's possible to block. Obviously, you can do tension again on this wire if you block it. If you leave this long wire like this, you may do the tension again or change the position. But now I will show you only like example how you may treat the wire. Okay, we put another bolt here. And we do it in tension. More stable now. always tighten it good, because the wire should be tightened really good. If not, it will be loosed and the frame became unstable and there will be infection around the wire. Always should be much good tension and a good tightening of the bolt. Okay, now we create this system for stabilizing proximal and distal part of the tibia. What we do, now we go to the more reality, like it is in an operation room. What we do, we practically remove this plate, because it was plate put in only for maintaining the bone. Now we go to real life and we create the fracture of the tibia. Okay, because it was this plate, if you see it, I remove this screws. Here. Because the plate was put in here only to show the fracture. Okay, another screw. Okay. Okay. We remove this. Okay. And now, like you see, we have a real fracture. What we do, maybe we create some kind of deformity. And what I do? Now, like I said, in the real life, the fracture is not so easy to reduce. Maybe it looks easier, but to demonstrate how we do reduction procedure, I do it a little bit of displacement, like this, okay? For example, you see this fragment now just a little bit in varus and displace it proximal part, displace it laterally in my direction. What I should do, I should reduce and stabilize this fracture, okay, like you see here. And now we start doing this reduction in the frontal view, okay? Because, like I said before, we should reduce this with olive wire. Now we use olive wires to put in the middle. We need to put them in the rings that was empty, and now we should put this wire at the level of this ring. Okay, and this is fracture. It's absolutely transverse, but sometimes there is oblique fracture. There is some third fragment in the middle, and we should stay a little bit below and a little bit above this fracture. Okay, I put in this olive wire, like you see, from the lateral part. This olive wire, I need it to reduce this translation. My aim of my treatment will be this, to do this kind of movement, and for this movement I will use olive wire. Okay, I put it here from the lateral side. Okay, like you know probably the technique of this introduction of the wire, olive wire, you need to put it like this. After that you cut the skin, small incision of the skin, and you put the wire that should be touching the cortex of the bone in this way. We stabilize, we have a point of touching of the cortex. Usually this wire have a good tip because the diaphysis of the tibia is really strong. You need to put it slowly, not doing too fast because it will be overheating of the bone and necrosis and infection. These wires and the trauma should be put in really slowly because the traumatic patient usually have really good quality of the bone. Young people. Okay, now we put this olive wire. You see, this permits me to do this kind of movement. We may do reduction, but before doing this reduction, we should put another wire up for opposite direction to the distal fragment, because it will be like a system that maintain the fragment. If we may move one fragment relatively to the other. Okay, what we do, we put this wire from here. Olive wire should be here on the distal ring. I do it from this side. Now, you see? Okay, like this. This olive wire opposite direction from the medial part to lateral on the third ring of the frame. And put like this. And like I said before, again, you cut the skin and our olive wire goes to touch the cortex, medial cortex of the tibia. Okay, remove it. Now what we do, like you see here, which fragment more displaced? More displaced, this fragment, proximal one. And the distal is more realigned. What we do for this, in this case, we put the fixed distal wire that we put lastly. I fix this olive end of the wire, okay, and I fix this wire. Yes, we use always a tensioner for the tension the wire, because it's really important to maintain original position of the wire. Now this way, like you see, I put all the wire practically that touches the rings. Sometimes the wire may be going a little bit oblique, and for attachment of this wire, that if they don't touch the ring, we should use the washers. And for now, we don't need them. Okay, what I do the tension of this wire, olive wire. Okay, you see me? Perfect. No, sorry, my wire is not touch it really good. This. It is displaced. You should pay attention. You see what this should be not happen, because olive should touch really good the bone. No, it's okay. It's easy, but maybe in the operation room you take the instrument, you tension like this, rotate it, and the olive wire should touch exactly the cortex of the tibia. Okay, after that I tight it. Okay. Again I do the tension. Keep the bolt, and I tighten the nut. Okay. Okay, now like you see, the distal system became much more stable. The distal fragment is blocked with the 3 wires, it's stable. Now what we have this intermediate fragment, this one is unstable. What we do, we need to see in the 2 projection with the fluoroscopy. We need to do control, and if you find like this, you see the distal fragment, displace it laterally, proximal fragment, laterally, and maybe you look to the lateral view. If you look to the lateral view, maybe this fragment displace it posteriorly. Okay, now we can't see it because you fix it, but maybe I can try to show you. I disattach the bone because okay, sorry, 1 second, like this. Okay, in the AP view, sorry again, okay. Like this you see it. In AP view, this fragment displaces it laterally, okay? But if you look to lateral view, maybe the bone, I don't know if you see it, no, lateral view, okay, is displaced posteriorly. Maybe for you difficult to understand because maybe I show you like this, okay? You see, I think it's easy to understand. There's a lateral view with the proximal fragment displaced posteriorly. And what we do, we manipulate with this wire, olive wire. We may do it displacing the wire posteriorly or anteriorly to reduce this displacement, okay? And what we do, we put it again here in original position. We manipulate this wire. I put the bolt on the part of the olive, maybe this. The bolt with the hole, we put this, yes. Okay, I do. Okay, now I put it oppositely in the way that there is displacement on the wire, like this. And the proximal fragment displace it laterally. You see? This is where I stay. This is lateral view. And from the lateral, our fragment displace it laterally. What we may do here, we put another bolt from this part of the tip of the wire. Okay. And we don't fix this part of the wire, where is olive side here. We don't fix it because it's only positioned on the bolt, but it's not fixed because we need to do reduction of the fragment. And what we do, we put here the tensioner for the tip of the wire. Okay. After that, what I do, I need some kind of instrument, maybe like a cocker or some kind of instrument. I put here in the wire, like this. You see, and the way I see how much this wire displacement, and I see how much I need to translate. My assistant do this movement, like you see. We tension the olive wire. Okay, and my instruments displace it, and the fracture reduce it. It's in this AP view. For you it is displaced, but for us here from AP view it is good. Now what we do, we may fix it part, fix another part, a little bit, not so much tightened, but you know that the wire is not moves. Okay. And now what? I show you maybe like this. Okay. Or maybe remove it here. This way we show you better. Okay. Maybe easy. Okay, perfect. And like you see, now that if you look in the AP view, no, okay, this, in AP view, it looks reduced good, okay, the fracture. But if you look to the lateral view, completely dislocated, you see, because we would do this reduction with the wire in one plane, but in another plane, this reduction is not perfect. It is displacement posteriorly. You see, this is anterior cortex, and the fragment, proximal fragment, displaced posteriorly. What we do in this case, sorry, Diego, come here, please. Okay. What we should do for reduction of this problem, I release again this wire, but only one side, one for another. Slowly, what I do, I release this, another part is fixed, the fragment don't move, and what I do with this wire, I bend it like this. And now you see the fragment's not shifting really good. What I do to do this shift I do skeletal traction, a traction between the proximal and the distal fragment. I distract from second and third ring, like this, and like this. Because with the tension of the muscles, the bone wants to be shortened. We do this distraction of all four rods parallel. Okay. And this way. My fragment's now free for movement. Okay. Sorry. Okay. Maybe like this. And like you see now, this fragment posterior, what I do? I take this wire and I bend it anteriorly. I bend the wire. Maybe better from this side, sorry. You see this wire? Okay, it's free. And the fragment displace it posteriorly. What I do? I bend the wire like this. I put the bolt in more anterior position, like this. Okay, now it is just a little bit reduced. I fixed it because in this way the wire don't move, not tension again. What I do again, because the displacement is not finished, there is again displacement there. I release another part of the wire. And I do the same movement. I displace it in one hole, maybe like this. You see, just more reduce it. And now it's quite realigned, okay? If I see this is realigned, what I do, I may do tension of the wire, control again in AP view, because in control, but the AP view is good enough realigned. Just a little bit of distraction. We tie this wire. Okay, and now to be sure that it's more stable, I do the tension of the wire like this. With this tension, if there is an arched wire like this, with the tension you may achieve more displacement or more reducing. You see, this was a small step. Now I do the tension. In this step, it is disappear, and I tighten it. You see? Now we have it two place reduced. We did a little bit traction. We did the realignment in AP view, like this. And with this wire, another wire, we did realignment in lateral view. Okay? And now we have just a little bit of tension. And the frame became now it's stable enough, good frame. Okay? I position it again down in the way I show you better, maybe all the images. Okay. Okay. Now we put it again the original position. Obviously, we all should control it in the two plane, because maybe you reduce in one plane and maybe displace it in another one. Now, like you see here, what's happened? I did too much traction maybe of this wire, and it looks like fragment displace it a little bit down. What we may do, we may do movement maybe by another wire if you want to reduce more or doing some kind of major adjustment. What we do, we put another wire from this side, because now the frame in the tibia, it's stable enough. We have 3 wires proximal, 3 wires distal, but we need to do more stabilization. For more stabilization, we use another olive wires. When we manipulate with the frame, when we do this distraction between the rings, in this moment you may release a skeletal traction, because if you have 6 wire and they good enough stable, if there is skeletal traction with the calcaneus, you may release. In this way you don't need to do the big tension of the soft tissue. Okay. What we do now for more adjustment, better control of the fragment, I will put another olive wire. I will put it from another side, like this maybe. Or put a more arterial. It should be better to put them in different plane, and above and below the ring. Okay. Okay, we put this wire. Okay, put another bolt. Here, if you have a rod in the middle or occupy the hole, you may put here or washer, or sometimes you use a square nut. We have this some way, dato quadrato. We have them, I saw them. See. Okay. This particular nut. Oh no, see? Like you see this maybe? And I'll show you like this. This is nut, it's high nut, like this. 6 flat 6 superficial and another superficial round. It's comfortable to attach to this bolt, like this. Oh. Okay. Like you see, it's comfortable to attach it and easy to tight. Okay, we tight just a little bit. If you need to do again the reduction, something, what you may do, release this bolt, don't tight it again. You attach another part of the wire here. And again, with the tensioner, what we do, because like you see here, there is a little bit of displacement. If I want, I may release another wire, but I think it will be enough that we may tension this. Good. I release this wire. Again, I put this kind of instrument like a cocker. It should be squeeze it, and you see how it moves. And I do the little bit of translation, like you see in my fragment. Now it's realigned it perfectly. If it's not enough, you may release the previous wire. If not, if only 1-2 millimeters, you may do like this. Now again, the assistant tight my wire here. Keep. Okay, tight it. Okay, no, oblique. Like this. Not so much, but 1 second. Okay, that's enough. Perfect. And now I tension more. Again. And I tie this wire. Okay. Perfect. Now, on my proximal fragment, much more stable. We reduce the fracture, and the fragment is stable. It can't move because now this bone, this fragment, squeeze it between two olive wire, one medial and one lateral. If you try to move it like this, it's impossible. It's too much stable. And now we should stabilize again the distal part below the fracture. We put another olive wire. Perfect. We do the same way, parallel to the ring, a little bit incline it and cross it, like this. Okay, cut the skin, put the wire inside, touch the bone. Okay. Again, if you find maybe in the lateral view that this fragment displaced, you may do the same manipulation with the distal olive wire, like I show you for the proximal part. The same way we may do it in the distal part, because when again we disattach it. Now we reduce it good with this manipulation here, like you see. Oh, okay. And the fragment is good realigned. But if you find, for example, that this fragment is down like this, no, displace it posteriorly, you may again manipulate the same way with another wire. This wire they put it first, or another wire that we put for the second, because we may bend the wire and we displace the fragment anteriorly or posteriorly. This manipulation of the wire permits us to do again a little bit of adjustment. Okay. Now we know it's remain good. Realign it. We put the bolt. And if you want, we may use again this high nut. Okay, attach it here. the same manipulation you may do with this wire. If you have a displacement in the AP view, you may do adjustment with the olive wire in tension from another part, or the first wire you may tension. Always do manipulation in the way that you reduce the fracture in the perfect way. Okay, put here another wire. This part I tight, better again, perfect. And we do the tension from this part. No, keep, yes, keep strong, because I bend it. Okay. And I need to. Okay. Okay. And now, like you see, it's a much more stable frame, because now the fragment can be displaced. Like you see, we can't move the bones because they squeeze it between two olive proximal part and the distal part completely stable. You see, I can't move them. It's so strong, it's so stable. It is stable enough for the patient when he not weight bearing, because the fracture like now is reduced and stable, but it's not enough for the future of this patient. This patient should walk, and we should guarantee stabilization or better of the leg. What we should add, because now we don't see if the patient have a fracture of the fibula, but usually it is open fracture or displaced fracture. We may do synthesis of the fibula too. It may be done in this moment, because now we see that the tibia is okay, but we need to do stabilization of the fibula. And I put two wires on the fibula, here and here. If you want, I show you maybe how we do this, but it's not so difficult. We use or smooth wire like this, or sometimes we use a big Kirchner wire. Maybe you have it in operation room, maybe 2.5 millimeters or 3 millimeters wire. But in this situation now, we will do this with smooth wire only. This. I put it a little bit more distal, because in this way, this wire maintains the syndesmosis. And if you have maybe displacement or diastasis of syndesmosis, you may use olive wire and squeeze the fibula on the tibia. After that, we fix it. I don't know, we don't have time now, but for fixing this, we use a post, because it's not possible to attach it directly to the ring. What we use here 2 holes or 3-hole post, male or female, how you prefer. Now we'll refine them. Yes, you see the distance. Look at here, like this, or like this. Choose the hole. Well, you put the wire like this here. Okay. and another part from lateral. Okay, we use again 2 hole maybe. Here, oh, this is small. We should take 3 hole. In the same way, you attach the wire here, put the bolt, and do the tension of this wire. This is a distal wire, and for the proximal one, what we do, we put another wire, please. For the proximal part of the fibula, we may do synthesis or with this crossing wire. It goes from the head of the fibula, like this. And it goes to the tibia. This wire is important to put it exactly on the head of the fibula. You may control it in the fluoroscopy because dangerous area, like you remember, the area in the neck of the fibula here, because in this area where it's exactly sciatic nerves go, peroneal nerves go here. And we should prevent this dangerous area, and we put it on the head of the fibula. You don't have any alarm in this area. Okay? If you use like this way, it will be stabilized at the fibula, and you may tension the wire with the bolt. But if you use this wire, usually it's too posterior. For the patient, it's uncomfortable wire because it goes too posterior in the proximal side, and the patient extend the knee. It is disturb him on the skin. What we may do this precision. If you use a little bit bigger wire, maybe 2 millimeters, 2.5. I touch here. And this big wire, I do. If you look here, I really leave the wire only on the fibula, on the head, but it is not presented on the skin because it is inside of the bone, but the soft tissue is completely free. If this wire is bigger a little bit, the normal wire, it may be possible to use this one, 8.5 or 1.8 millimeters, but if you use bigger, it is much easy, a little bit more stable, this wire, okay? And you attach this wire only with a bolt on the proximal ring and destabilize it, okay? Now we do the last step. If you want, maybe we don't have too much time, but I show you only that for better stabilization of all the frame, we may put here again the half pin, or if you prefer to use wire, maybe you may use third wire proximal and distal, or for easy stabilization, we may use the cubes. You need to, yeah, we may put half pin or this. Short one. Yes, this short one. Okay, so mi sono appunto. Okay, and what we do, we use a small bolt or medium one here. and you may do it, or depends of the half pin they use. It is a self-penetrated half pin like this. We put one here. Then we put the bolt, and we may put another one on the distal part. Yes, usually we put from anterior medial side because the bone there is easy to see. Media. Okay. And we put this. Okay. We are quite finished. Okay. Practically finished. We put this small bolt to fix it. I show you in the other workshop how we fix this half pin. In any case, this system now is really stable. Like you see, the proximal part, they have a two wire or third wire for the fibula, 3 wires distal part, 1 half pin, the fragment fix it with the olive wire. This frame really stable, and the patient may weight bearing immediately after surgery. You adjust it, control it, and now it's practically finished for this patient.